Hi everyone. This is a Banksy vid in VR just to protest against COVID. But let's move over and just learn a little bit about COVID. This is about the ARDS ratio. So this is our effort to sort of give you some support and understanding of what ARDS is and how you can use that to diagnose and monitor your patients at the bedside as you take care of them during this COVID period. So acute respiratory distress syndrome. Usually it's diagnosed and then monitored by a ratio, so just a simple equation. There is some variables which we'll mention quickly, but essentially it's alveolar and capillary damage within the pulmonary system, and it causes sort of an acute pulmonary edema type effect. There's a complicated inflammatory process that comes with it, but the core basis is around that. This equation here, which is your PaO2 divided by your FiO2. So your PaO2 is your partial pressure of oxygen in your arterial system, and the FiO2 you may have heard of before, which is your fraction of inspired oxygen within the atmosphere. Now, really important for us to understand is that once we start giving supplemental oxygen, then it's up to us to understand and to monitor that oxygen. Hypoxeamia is a thing. You know, we may have learned that giving too much oxygen can be harmful, but we do know in these COVID patients that hypoxeamia, so a low level of oxygen in our blood, is a core reason for high mortality. So in these cases, we're giving oxygen as much as we can, but we're being extremely mindful of doing that in a way where we don't create aerosols. Now, there is a variable in relation to the FiO2, which is PEEP. Now, if you're giving high amounts of PEEP, this equation just does change a little, just to be mindful of that if you work in intensive care or in some resus departments in emergency. All right, now, let's go on a holiday. Wouldn't that be nice right now, I tell you. But we are at the top of Mount Everest. Now, why are we here? That also is a great question. We're 8,800 meters up, right near the stratosphere, and the air pressure is significantly different. And due to that air pressure, the way that we absorb oxygen from the atmosphere is quite different. People might have heard of altitude sickness. But the things that you really need to understand is that up here we have 250 millimeters of mercury, and at sea level we have 760 millimeters of mercury of air pressure. And that changes our ability to absorb what we know as the fraction of inspired oxygen within our alveoli. Now, I'm going to make my way down to the beach. We might just come up here. I might actually just go near where I live. Let me just see if I can find it on the map. So, before we start to understand what is abnormal, it is so important to understand what is normal, particularly when it comes to respiratory mechanics. Now, this can be very technical. There's a great little textbook by a guy called West on respiratory mechanics, but the simple process of breathing in and breathing out does get quite complicated once you start to look at the basic science. And, you know, the Milky Way is quite impressive there. Sorry, getting a little bit distracted. Okay, so as we're moving along, when we breathe in, that's an active phase of respiration. And we're using our muscles, as we know, our sternomastoids, our scalenes, our intercostal muscles to breathe in. The diaphragm goes down. We draw oxygen in by creating a negative pressure within our chest. So just get your head around that. We create a negative pressure in our chest, and it draws oxygen from the atmosphere into our chest. Okay? Now that's important because once you start to learn about non-invasive ventilation, you start to learn about how we deliver positive pressure ventilation. But our natural state is to use a negative pressure to draw air in. Okay? Obviously then if we cough or do something like that, then we're creating a positive pressure, which is an exhalation process. All right. So why are we at the beach? What does that matter? The thing is, I want to give you a visual key to understand that normal respiratory mechanics happen at sea level. Now, if you can master this, then as you go into ventilation and start to learn more, the abnormalities will come a lot easier. Okay, so 760 millimeters of air pressure at sea level and 21% of oxygen. Right, now let's go into the anatomy and have a look at respiration. So this is a a 3D model of the thorax, essentially. We have the diaphragm here, which is the largest muscle of respiration. Now, this may be revision for you, but it's good quality revision right now in relation to COVID. Now, the diaphragm is essential. It provides two cavities, so essentially the thorax and the abdomen. You can measure intra-abdominal pressure using a urinary catheter, and obviously we can measure intrathoracic pressure sometimes using our CVP as a guide from our central lines. What I'm going to do is just pull up a cadaveric image here of what this actually really looks like in real life. Now, I can't stress enough the importance of understanding the anatomy when you start talking about respiratory mechanics, because it's easy enough for me to say that, oh, you use these muscles to breathe in and expiration is passive. But, you know, for you to have an understanding that the right and the left phrenic nerve innervate the diaphragm, allow the diaphragm to move, and that's where we create our, essentially our pump for respiration. Because then we can understand that if we have nerve dysfunction, then our phrenic nerve won't work as well, and that's going to impact on our respiration. So everything has a relationship, and it's gathering a knowledge of these relationships that allows us to build our knowledge to be better at the bedside. There you go. So there's a clear, so feel free to pause the video if you wish to have a look at that cadaveric image. It shows the posterior perspective of the lungs and the thoracic cage. So we're just going to dig into the anatomical model here a little further. You can see the trachea there, it bifurcates. So air comes from the atmosphere, hopefully from the beach. You don't get any beer or food into your trachea, that's your esophagus. So once the air comes down the trachea, it bifurcates to the right and left and moves into your lungs. Obviously we know the right lung has 3 lobes, and then as it goes through the different bronchial segments, it comes into your alveoli. Now the alveoli is where ARDS happens. Now, essentially what is happening is that we're getting alveolar and capillary damage. Now, that damage generally produces, is produced by inflammation, apoptosis, necrosis, and increases the alveoli capillary permeability. And what the hell does that mean? It means that the alveoli, as we can see here, and that little spiderweb network of the cardiovascular system that sits around them, where diffusion takes place, become permeable. So that means they become a little leaky. So let's have a look. So as I come in here, you can see this little network of veins and arteries. They start to leak and the fluid comes into the alveoli rather than staying within the system. So then essentially we get this sort of pulmonary edema type picture across the lung. And they talk about this sort of interstitial classic COVID x-ray, but essentially it's this sort of wet lung that goes straight across the right and the left. And it's this, it's the alveolar fluid that develops due to the alveolar damage secondary to ARDS. So essentially the core problem is hypoxeamia. It's how do you get the oxygen into the trachea, down the bronchioles to these alveoli, but get it through the water that's in the way due to the inflammation damage that COVID has caused. So this is the challenge that we have at the bedside. And this is what we're going to be monitoring as nurses. Okay, so the general equation is that we should have under 300. So PaO2 divided by FO2 should be over 300 to be normal. Okay, under 300 is abnormal. Okay, I'm handing over to Rob.
Hey, it's Rob Timmins from ECT for Health. That was great, Brad. Gee, I love standing up there on the roof of the world, Mount Everest. One of the places definitely on my bucket list. Look, we're just going to unpack a little bit more about the PF ratio. And to understand that PF ratio, we'll just come back to the Mount Everest thing. The PF ratio is made up of 2 values. The first value is the PaO2. The second value is the FiO2, and that's the amount of oxygen that a person is breathing. So if we would have a look at the FiO2, let's just start very quickly with that. Now, Brad, a moment ago, had us up on the top of Mount Everest, where the atmospheric pressure was around about 250, he said about 250 millimeters of mercury. And what that literally means is that that's the barometric pressure. The weather forecasters will probably put it into hectopascals, but the unit of pressure that we measure in medicine is millimeters of mercury. So this is 250 millimeters of mercury of atmospheric pressure. Now down here at sea level, where most of us are breathing down here at sea level, we're breathing room air, which is 21% room air, and we're breathing that room air at 760 millimeters of mercury. So that's what our pressure is down here, 760 millimeters of mercury. And to simply calculate how much oxygen that actually is, it's still 21% oxygen, but it's 0.21 of the 760 that we're breathing. So you're breathing 760 air, 21% of that, 0.21, is oxygen. So that number comes out to about 159.6. Let's be friends and just round that up to 160. That's the oxygen you're breathing right now that you're bringing into your alveolus. You're bringing in that 160. When your FiO2, your fraction of inspired oxygen, is 0.21, 21%, you're bringing into your lungs an oxygen concentration in terms of a pressure of 160 millimeters of mercury. So that's the first point. Now, let's take that up onto the top of Mount Everest. If I was up at on the top of Mount Everest, there I am standing on the top of Mount Everest, and on the top of Mount Everest, my atmospheric pressure is only 1/3 of what it is down here on Earth. This is only about 1/3, 250 millimeters. I've still got 21% oxygen, or an FiO2 of 0.21, but I'm only breathing 0.21 of 250, not 0.21 of 760. So my oxygen concentration is going to only be about 1/3. I might only be breathing oxygen at about 50 millimeters of mercury up on the top of Mount Everest. And that's just not enough concentrational pressure of oxygen to be bringing into my lungs. This is why our climbers who go up into the Andes and up into the Himalayas and probably need to have oxygen. Okay, so let's talk numbers. FiO2 at 21% is 0.21. That's what I have breathed into my lungs, 0.21. And because this is called the FiO2, this is referred to as the F value in that equation that we call the PF ratio. The PF ratio. Now, deoxygenated blood is going to come through the lungs and go back to the left heart. It comes from the right heart, deoxygenated, and it returns to the left heart to be pumped around the blood, well oxygenated. And we can measure that in arterial blood. With a set of arterial blood gases, we're going to look at the value called the PaO2. On room air, it's normally 80 to 100 millimeters of mercury. So let's measure this patient who's breathing room air, 21% oxygen at sea level, 21% oxygen. And let's have a look at what their PaO2 is. Let's give him a nice little average PaO2 of 90. We've now got our P value. That's this value up here. I'm just going to change colour to blue to highlight that. So this is the P value. And we've got our F value. That's how much oxygen the patient was actually breathing, 21%, or an FiO2 of 0.21. Now, this PF ratio, as the name implies, is a ratio, which mathematically means the P is divided by the F. So let's take the P. Our patient's blood gas showed us 90. He's breathing room air, which is 0.21. And if we do that simple maths, 90 divided by 0.21, we get a number that's about 420-ish. You can probably pull out your iPhone or your Samsung and calculate the exact number. But it certainly is north of about 420. That is what the PF ratio is. Now, what Brad talked about earlier on in the video is that he said that when somebody has got a PF ratio that is greater than 300, normally between sort of 300 and 500, and you can see that your PF ratio, if you're breathing room air at atmospheric pressure, and your PaO2 is 90, you can see that your PF ratio sits between that 300 and 500. That's considered to be a normal PF ratio. But when patients develop ARDS and they start to get damage to their lung membrane, their lungs are filling up with pus, filling up with pulmonary exudate, filling up with all sorts of fluids, what we're actually going to see in those patients is a situation where their PF ratio will plummet. Now, if your PF ratio drops below 300, this is referred to as acute lung injury number 1. If your oxygen gas exchange is so bad that it actually drops below or equal to 200, that's very severe. That's called acute lung injury 2. And the other name for it is acute respiratory distress syndrome. So ARDS is usually diagnosed when other factors have been met. ARDS is usually diagnosed at a PF ratio of less than 200. So how do I get to 200? Well, there's a really simple little rule. It's called the 50-100 rule. If I measure somebody's PaO2 and their PaO2 was 100, and that patient was breathing oxygen with an oxygen mask in the ward, and that oxygen mask was delivering them 50% oxygen. The FiO2 there is 0.5, is my FiO2. Now let's have a look at how that maths would play out. My PaO2 is 100. My FiO2 is 0.5 in this patient. And if I simply took that 100 and divide that by 0.5, or I took that P value and I divided it by the F value, then I'm going to have the answer of 200. That patient that's got a PaO2 of 100, whilst breathing 50% oxygen, is sick. This patient will probably be supported to have a diagnosis of ARDS. And that's what our PF ratio does. Hope you enjoyed the session. I certainly enjoyed Brad's stuff. I can't wait for my headset. See you later, guys.